Hello, hello. Good evening, everyone, and welcome to another episode of Telehealth Tuesday. This is your go to podcast for modern healthcare and wellness solutions. I'm Dr. Michael Bookhardt, your host, and today we have a very special episode lined up just for you. I want to let you know before we begin that Telehealth Tuesday can be viewed on multiple platforms, including our YouTube channel. That's Dr. B TV. That's the word doctor spelled out. DOCTOR, the letter B is in boy, TV, and also our Facebook and Instagram pages alike. So make sure to follow, like, share, and subscribe to help support this amazing program. Now, before we bring these two gentlemen out, they're backstage and excited and ready to talk to you, but I want to get you a little information on these two gentlemen if you don't already know. Let's start with Dr. Vernon Rayford from Holly Springs, Mississippi. He earned his doctorate of pharmacy degree from Ole Miss in 2005 and a doctorate of medicine degree from Vanderbilt in 2009. He completed residency training in internal medicine and pediatrics at the Massachusetts General Hospital and Harvard Medical School. He works as a faculty member of the internal medicine residency at North Mississippi Medical Center. He previously served 8 years as a primary care physician in Tupelo. He currently serves as medical director as well for the Good Samaritan Health Services, and he's board certified in internal medicine, pediatrics, and also obesity medicine. Now, if that wasn't enough, let me bring up my frat brother from the greatest fraternity known to man. That is a phi. Dr. Freddie Earl Kency Jr., board certified emergency physician and native of Jackson, Mississippi, who's passionate about men's health and mentoring. He currently resides in Madison with his lovely wife, the Dr. Jasmine Kency, and their three lovely children. That's Fred, Elijah, and Kylie. He received his Bachelor's of Science in Biology, magna cum laude, from Alcorn State University 2007 and Doctorate of Medicine degree from the University of South Alabama College of Medicine in Mobile, Alabama in 2011. Dr. Kency is a third generation military man. We appreciate his service. He proudly served in the U.S. Navy for 4 years and was deployed to Africa and Europe prior to his honorable discharge. He returned home to Jackson to complete his emergency medicine residency at UMMC. He currently serves as a community emergency medicine at Baptist Hospital here in Jackson, and assistant professor of emergency medicine at UMC as well. He continues to serve the community and state as the leader in Alpha Phi Alpha Fraternity Incorporated, currently serving as the District of Mississippi Chief of Staff and Rose Lambda chapter president. Look, I'm just going to get these guys in here because I feel like I've said enough. I want you guys to hear it from them. So without further ado, ladies and gentlemen, stand and cheer or sit and cheer for the Dr. Vernon Rayford and Dr. Freddie Earl Kency Jr. Give it to him. What's going on, gentlemen? How you guys feeling? Oh, I think y'all might let's unmute unmute those mics. Sorry about that. Okay, there we go. Yeah, man, how you guys doing?
I feel like a celebrity after that introduction.
I know. I've never had a round of applause, so I'm gonna let that marinate for a little bit.
Oh yeah, man. I'll tell you, when I bring you out, man, on this show.
That's what I'm talking about.
Man.
Thank you for having us. We do appreciate the intro. Definitely appreciate the opportunity to come out and spread some knowledge, spread some love, and hopefully somebody takes something away from this that helps them in life.
Yeah, absolutely. Absolutely, man. We've got viewers from all around. We're all live on Facebook. We are on Instagram, so I'm switching back and forth. We've got some new folks in there. I'm going to say hello. I see David, the Pierre docs, Dr. David Pierre, Lanika's there, Crystal there. We got some new folks. Thank you all for being loyal supporters. And we're also on Dr. B TV on YouTube and LinkedIn. So, man, look, I read your bios, but I would love for you guys to tell the audience anything else that I might have missed or any fun facts or interesting things about yourselves, man. Let's start with Dr. Rayford.
Yeah, so North Mississippi, glad to be back home in Mississippi. Married a Mississippi girl, came to Tupelo 13 years ago. And really, really excited. Fun fact: when I'm not doing all that I'm doing, I actually run marathons, and so I'm preparing for the Tokyo Marathon in March of next year.
Awesome. Awesome. Is this going to be, if you're going to Tokyo Marathon, I know this is definitely not your first rodeo.
No, this would be number 15.
Number 15.
Yeah, it'll be
Ooh,
number
man.
15.
One day
So yeah, I imagine I'm kind of winding down on the marathons, and but I got a couple more in me.
that's awesome, man. Man, Dr. Kency, man, anything you want to tell our viewers before we get started, my brother?
Well, I do not run marathons. That is one of the longest I've done is I did a 10K when I was stationed in Djibouti, Africa. It's the Horn of Africa is north of Somalia and Kenya, and it gets so hot in the daytime that we had the PT at like 4 in the morning. So you
Wow.
have the PT before the sun comes up, because once the sun comes up, in the military, you can't PT once it's above 90 something degrees outside. It would literally get to 90 something degrees within, 30 minutes of sun up.
Mm.
So we had the PT at like 4 in the morning. And then you PT, go shower, then you can go back to bed. And then you can get up and actually do your work day. And so we did our 10K. We did our 10K at like 2 in the morning. And
Wow.
Oh my
that's the
goodness.
coolest time in Djibouti, Africa. So the longest I've done was a 10K. The time was not great, but I did finish. I didn't walk. I didn't walk any of it. I jogged the entire time. It was dusty. It was long. It was still hot, even though it was morning time and there was no sun outside. So kudos to you for being able to knock out 14 marathons. That is definitely
Yeah,
a serious. Uh, that takes some serious mental effort outside of this physical effort. So that is definitely a kudos for you. But
absolutely.
from Jackson, Mississippi, I'm a Provine High School graduate. So when I left the military in 2015, I came back home, and I actually, instead of following a woman, I actually drug a woman home with me. So my wife is also med-peds. She practices internal medicine and pediatrics at UMMC. She's been doing so for the past 10 years, recently promoted to associate professor. So she's really
Awesome.
doing her thing over there. So she's
Congratulations.
really enjoying it, loves the kids, loves the adults. So she loves every part of medicine just like I do. Um, I actually drug her here. She's actually a graduate of Spelman, went to medical school with me down at University of South Alabama. And then when it got time to apply for residency, I said, "Well, I'm going home. What you gonna do?" So
Oh God.
luckily, she played my bluff, and she came on to Jackson with me, and we've been kicking it here now for since 2000. We graduated 2011, so we've been here now for almost 15 years,
Oh,
and
wow.
we've built our base here. We don't plan on moving anywhere, so we love Jackson. We love the surrounding metro area, and so we'll be here for quite some time.
Awesome. Awesome. And we appreciate all the information. And then we'll let you know some fun facts about these gentlemen a little bit later on and some of the things they're into. But we'll go right here. Let's go right to our first question. And as you guys know, we are live, and so this is the place. You've got the specialists here. We are all here to answer your questions. I've got two tremendous guys, wealth of knowledge. So we would love for you all to ask your questions. No question is off limits. Well, there may be one or two I can think of. Anyway, but well, one of our first questions. I'd like to. I'll send this one to Fred, to Dr. Kency. Why do you think? Well, actually, we'll send it. We'll start with you, and then if you want to chime in for Dr. Rayford, why do you feel that minority communities in Mississippi are hit harder by health problems, such as diabetes and obesity and such?
A lot of it, I think, is the access to medical units, access to just medicine at all. If you go up into the Delta, a lot of those places, they're medical deserts, and what that means is just like when we use the word food desert, there are times where you can leave someone's porch, drive 40 minutes in each direction, and not see a single ER, not see a single practicing OBGYN, not see a single practicing endocrinologist, not see a single practicing cardiologist. And so when you have a location, that huge bubble of lack of medical access, lack of medical knowledge, lack of medical insight, there's not people. And then you look at the telehealth, there are places in the Delta that don't even have access to broadband education. They can't even watch your show because they don't
Mm-hmm.
have the kind of internet needed to even look at these kind of videos. And so when you look at things like that, it's actually pretty easy to understand why these
Mm-hmm.
places and these people have such terrible medical outcomes, and because they're getting their medical knowledge not from people with the MD behind their name like you, brother Bookhardt, or people with the PhD, the PharmD like you, brother Rayford, but they're getting their medical knowledge from grandmama and granddaddy. Not to say that grandmama and granddaddy don't know some things,
Mm-hmm.
but
Right,
they
right.
can't tell you how to treat hypertension. They can't tell you how to treat diabetes. They can't tell you, or sometimes it's I had a grandmother. Both of my grandmothers have passed away now. I have older siblings and I have older family members, and I go to family reunions, and it's always going to be the conversation of, I know you're not at work right now, but let me ask you this right quick.
Right, right.
Some of the things that I get asked, and a lot of times they're asking me, is this true? They want to know this thing they saw or heard or whatever. Is this real? Is it true? And it's like, absolutely not. Beets will not make your blood pressure better. You
Right,
know,
right,
uh,
right.
drinking apple cider every day will not replace your ACE inhibitor if the doctor has said you need an ACE inhibitor.
Mm-hmm.
So there's certain things the family is going to listen to because they don't have that access. So I'm definitely a believer that a lot of times the medical problems that we deal with as a minority community, are happening because, one, we don't have access. That community does not have readily access to health providers who can give them the education needed. And then secondly, they have the opposing ideas of people like, not to be a polarizing time on your podcast, but they
Mm-hmm.
have the ideas that are being spread by our government that things like Tylenol cause autism. When you hear the person who is supposed to lead the the United States, predominantly health organization in our government, say that Tylenol in pregnant women causes autism, like, how do I as a physician go back and have to refute this to every single patient that comes in and talks to me, and I have to tell them that there is not a single, in the largest documented study done by the American College of American, that is referenced by the American College of Gynecologists, ACOG, which is the governing body of OBGYNs.
Mm-hmm.
They have made it very clear that there has been no clear association, no clear causation of Tylenol to autism. But yet we have people in our politics and people who are on TV, and their voice are going to 300 million people every night when they talk.
Absolutely.
My voice, I don't know how many people are going to watch your podcast tonight, but
Yeah.
my voice isn't going to get 300 million. So
We're not gonna
I'm
get
not
that,
gonna be able
but
to-
we
I can't
well,
refute all that information that he put out, on CNN
yeah,
and MSNBC and Fox News. And so, it's
yeah.
hard to fight these kind of things. And that's why our community suffers, because sometimes they would rather listen to, some of the people that don't look like us than to listen to
Mhm.
us. So,
Well, I'm before Dr. Ray, before if you want to chime in, but I got to get in on that because you said
Yeah.
polarizing. I want y'all to know, look, hey, this is that the good thing about we're not syndicated yet, and we don't have, so this is something that we just do out of the goodness of our hearts to give back to the community. And so with that said, hey, we can say whatever we want to say. I've had all kind of guests. So look, there's no topic, my brother, that's off limits. I'm going to second what you said because you're right. That's absolute foolishness. And like you said, when people come in, they trust these guys. They look up to these people. the talking heads on TV and our leadership and in the country, and it's a shame. So, and real quick after if you want to respond to that, Dr. Rayford, because I got a question here from Dr. Salida. I know you guys remember she was in residency with us, Fred. I know you know her, and she's a maternal fetal medicine specialist. So it's funny that you just said that and about ACOG. So she on our Instagram page has a question. So Dr. Rayford, did you want to chime in on anything yet?
Uh, I mean, I guess back to the original question about, high rates of chronic diseases, some other factors, these chronic diseases run in families. So diabetes, hypertension is kind of highly inherited. So you kind of have these conditions that run strongly in families. You have families that are living in the same environment. And I think what we are going to kind of recognize and talk more and more about it is, if you wanted to map out where the poor health outcomes are in Mississippi, all you need is a zip code. And so the environmental impact on chronic diseases and unfortunately the complications, heart disease death and cancer death, I mean, you can look at a map. And so some things that kind of make sense, healthy, safe water is a big deal. Healthy, safe air is a big deal. Free from pollutants is a big deal. And so I think that adds also to it. Where does the polluting industry go? It doesn't come to my neighborhood because my HOA would fight it.
That's right.
But it does go to places where the HOA won't fight it. And, maybe there's some intentionality to it. I mean, where we can figure out where lots of cancer is. We can go to parts of Louisiana. And so really adding that environmental aspect. And what that tells me as a physician, there's only so much I'll be able to do in the exam room in terms of, what communities need and the kind of transformative nature of my work. I'm going to have to get out the exam room. I'm going to have to be in the community. I'm going to have to be advocating and actually speaking to decision makers and just saying, pollution anywhere is a challenge because those folks don't stay. And so those poor health outcomes are going to kind of come back to us. And there's no secret that Mississippi's problem is a problem for all Mississippians in terms of health rankings, that the, people in Mississippi who fare better are in worse health than the worst people in other states. And so if all of Mississippi still allows kind of subpar health care for some, the health care in Mississippi is subpar.
Yep, absolutely. Salida, are you still on our Instagram? She wanted to know, with the lack of access for a lot of Mississippians, and now with the misinformation from the government. Okay, I see you there. And now with the misinformation from the government, which is what Dr. Kency was just referencing, how do you guys think that this will affect infant mortality? And what are some ways that this can be mitigated? And then she later adds, specifically thinking about vaccines too. Let me see if I can put that on the. I don't know if I can put that up, but want to make sure you. So I guess we may give that one to. I know Dr. Rayford did med peds. I don't know if you may want to comment on how do we think all this will affect infant mortality? In some ways, this can be mitigated.
Yeah, so I don't think it's going to improve the problems that we're already having in Mississippi. And so in Mississippi, we've already announced maternal and infant mortality as a public health emergency, and announcements out of the CDC and, kind of the current posture of HHS is not actually helping us. And so I will say, I know for sure that is not going to help us. I also acknowledge that I just don't know. It's one of those hard times that the frenzy has been kind of emotionally, psychologically taxing. And so I joke with my colleagues. There's this acronym called FOFO. We're just in the FO part of FOFO. We've already fought, and we're in the faux part, and everything is just a faux. Here it's a
Sound
faux.
like Clay Edwards or something up in here.
Yeah, and so I mean, I have to just say, look, I wake up every day and figure out what I can do, as small as it can be, to kind of help in the FO part of it. But I do know that I will say it's going to take more than the pediatricians. It's going to take more than the obstetricians for our maternal and infant health, because pregnancy doesn't occur in a kind of vacuum. And so on the internal medicine part, we're going to have to kind of step up and make sure that we're maximally supporting the women, young women in particular. On the pediatric side, we're going to have to make sure we're maximally supporting kind of the young women in those kind of those fertility years, and just kind of not have a hands-off approach. I know some aspects in pediatrics, our young girls, when they have a baby, they're emancipated, so they're moving from pediatric care to an adult care, that the model is totally different. So I do know that internal medicine docs, pediatrician, family medicine docs are going to have to kind of, to consider pregnancy as something that involves us as well, and kind of rethink our hands-off approach, just because, a lot of the complications are, a lot of the complications kind of happen after the delivery, and particularly for infant mortality. And the other part is these infants are actually, they're living in a setting where there's adults there, and the health behaviors or the health of the adults are impacting the adults and those infants.
Absolutely. Uh, Fred, you wanna get in on that one, or we gonna keep moving?
Yeah, I think I think Brother Rayford said it all really well. Biggest things is that it's going to take all the physicians in Mississippi to get this problem under control. A lot of it starts in the emergency room. Believe it or not, we're a lot of times the first time that women figure out that they're pregnant. They come in with abdominal pain. They come in with abnormal uterine bleeding. They come in with some kind of complaint. And us as an ER doctor, if you're in childbearing ages, you're gonna get a pregnancy test, and then
Mhm.
boom, we're the ones walking in the room saying, "Hey, did you know that you're pregnant?"
Right,
And
right, exactly.
and definitely
Exactly.
preaching to these new mothers, sometimes mothers who have been mothers before, most of the times brand new, never been pregnant before, the education part, hey, make sure you take your multivitamins, make sure that your folate levels are maximized for neurotube development and all these other things that are very important in the very early stages of the development of these babies. Making sure that we're educating on all the things that can cause issues with childbirth. No more ibuprofen, no more aspirin. Make
Mhm.
sure that you're drinking plenty of water. Make sure that you're getting plenty of sleep. Make sure that you're not smoking. You're not using alcohol. All the things that could possibly cause issues with infant mortality, and all the things that could possibly cause issues with childbirth mortality. We have to be making sure that we are discussing these things with the parents, with the mother, with the father, right at the beginning. So
Mhm.
there's, not this huge delay where a lot of times, we see this first time pregnant mom, we say, hey, you're pregnant. We get an ultrasound that shows that there's a baby in the uterus. And then we say, all right, discharge, follow with your OBGYN, which
Mhm.
sometimes can be, for someone who has great insurance and has a great relationship with the OB doctor, that next visit could be in 2 days. For someone who has no insurance and hasn't had a OB doctor visit in who knows how long, that next visit may be 6 weeks from now. And so I think we definitely have to do a better job in ourselves of making sure that we get to um, giving giving these patients the information they need to make sure that they are able to start the journey early with all the right information.
Absolutely. Absolutely, man. I think that was very, very well said, my brother. Um, let's uh, let's go to our second question here, um, and I'll say let's go back to Dr. Rayford.
Mhm.
How much would you say that diet and exercise really matters when it comes to preventing weight problems in children and young adults?
Yeah, I think it's really important, not just in prevention, but just it's really important across every aspect of life and across the life spectrum. It's true that the habits that begin early on are they have some lifetime consequences. But what's really interesting is, really rethinking kind of how we really rethinking how we teach those habits. But nutrition, healthy nutrition is always good for you. Healthy movement is always good for you. And even when the chronic diseases are there, healthy nutrition, healthy movement, stress management, better sleep, all of those things are part of the treatment too. And so I think one disservice that may have been kind of made in the communities is that we physicians love to put really clear lines between things, and that kind of prevention treatment line is kind of, oh, that's public health. And so me as an
Mhm.
internist is like, well, I'm dependent on the Mississippi Department of Public Health to kind of be out there promoting healthy exercise and healthy nutrition. And then, the chronic conditions are being diagnosed in my office. And I'm still saying, well, I'm going to let the health department teach you about managing that chronic disease. I'm going to let them teach you about the nutrition and stuff like that. So I think, as a physician, you know, these are foundational things, but this isn't new. This isn't, one aspect of the kind of make America healthy again. Some of that focus on nutrition and exercise, there is a focus on it, but again, some of the other conclusions that come through. So it's almost like a focus to kind of convince you, and then silly things happen, like what you're currently seeing. So it's saying, yeah, processed food, yes, processing food takes away a lot of things and adds stuff we don't need. Unhealthy environment is unhealthy, but that's not actually we're not really making those making that impact. We're not supporting those communities that are exposed to kind of pollution and stuff like that. So, but nutrition, exercise, stress management, sleep, man, they are foundational. And if you look at organizations like American Heart Association, they have something called the Great Eight, and of those eight kind
Mhm.
of features, a lot of those are what we would have classified as lifestyle. But I mean, they are foundational. But I want to also say that, when a condition is diagnosed, sometimes, although lifestyle could have prevented it, lifestyle is not a treatment for cancer. It can help cancer treatments, but it's not a treatment for cancer. And so, no amount of kind of refocusing on lifestyle is going to make that prostate cancer go away. You got the prostate cancer. The prevention part, now we're in the therapy part. Lifestyle is still beneficial, but we don't want to lose focus, because a lot of our people are going to be hurt by that kind of unclear message of, oh, well, if you didn't do the lifestyle, let's do it now. But the cancer's been diagnosed, and
Mhm.
it's a different conversation.
Yeah, absolutely.
Yeah, and I definitely agree with everything that Brother Rayford said. Um, you can see it, in the emergency room. When parents come in, it is very rare that I see a child who is overweight, who is, I mean, not like a little overweight, I mean, like drastically overweight. I mean, like 99th percentile for weight, 99th percentile, just maxed out, and the parent isn't the same. And so it is very clear that children, 7-year olds, 8-year olds, 9-year olds, 12-year olds, they're not cooking for themselves. They're not buying their own snacks. They're
Mhm.
not buying their own food. It can be controlled what they eat at school, but once they get home, that's all based on what mom and dad's or grandmother's eating patterns are. And so a lot of times when you see children who are significantly overweight, it's going to be directly, you can look that direction at who's sitting in the chair that brought them here and say, I can tell why this kid is so far overweight. It's because they're choosing to do the exact same things for the child they do for themselves. They're feeding them foods that are going to gain them the most weight. They're eating a lot of processed foods. They're eating a lot of high fructose corn syrups. They're eating a lot of foods that should be done in very low moderations. They're doing the exact opposite of what needs to be done, and the exact opposite I know of what's being taught to them by their pediatricians and their med peds and their family medicine physicians. And so, as much as we possibly can do as physicians, and a lot of times when you try to educate about that, you sometimes create discourse in that patient relationship. Because if I go, if a patient comes in to me in the emergency room, because I'm just a lowly old basement emergency room doctor, when patients come to me in the emergency room, and even if it's for my ankle hurts, or it's because my leg hurts, or because of whatever it is, and if I mention anything about weight to that child, to that mother, to that father, and they themselves are markedly overweight as well, you automatically get this kind of wall that goes up. And it not only affects your ability to kind of practice good medicine right then, but then you become the enemy, not just you, but your colleagues in the future. And so now I feel like sometimes I've prevented the ability of their primary care doctor to bring up these conversations in the future, because now, his ankle is hurting because all y'all want to do is say his ankle hurts because he's overweight. Well,
That's right.
his
That's right.
body was not built to carry that much weight at this age. And so when you come to me and say he's complaining of knee pain, he's complaining of hip pain, he's
Mhm.
complaining of ankle pain,
That's
and I
right.
tell you that I think it's because his body is carrying much more weight than it was ever designed to carry, then I don't know what other answer you're wanting.
Right.
I'm not going to recommend that your 6-year old who weighs more than my 12-year old. I'm not going to recommend he goes to see orthopedics for his knee pain. It only happens after he runs at school. Like, there's certain things where it's like, the obvious is the most obvious, and it's sitting right here in front of me. And so a lot of times it's learning how to navigate those conversations with family, but also understanding that the family is kind of the reason that some of these weight problems are happening, and we know that the diet is definitely lacking. For me to go and get a Cobb salad with some vinaigrette dressing and some good blue cheese and a good this, that's a $14 salad when I go to lunch.
That's right.
But I can walk right across the street to McDonald's and get a double quarter pounder for like $4.
Oh, yeah, the
And
four
so,
for four, the Wendy's, 4 for 4.
Yeah. Yeah.
so
Yeah.
I can't always blame the parents for making the most financial decision for their household. When it comes down to it, they have to put food in their kids' mouths with the amount of dollars they have to spend. And I know that it is a terrible thing, but it is expensive to eat healthy. Like, I
Mhm.
mean, come to my house
Absolutely.
right now. I can tell you, like, it is expensive. My wife buys most of the groceries, and but I see the Costco bill, I see the
Mhm.
Kroger bills, I see the bills. It is ridiculously expensive to try to
It
put
really is.
healthy food every single day in your child's mouth. Though we do the best that we can, we know that it's tough, and so it's a hard fight. It's a generational issue. It's a financial issue. We got issues kind of in both directions, and all we can do is just keep fighting the hard fight.
Yeah.
Yeah, absolutely, man. Couldn't agree more. We've got some great comments here, and I don't know. I guess you guys can see them. The Justin Turner, Dr. Justin Turner, has joined us, and he's made some great comments. Says it's good to see my friends, Dr. V. Ray Rayford and Dr. Freddie Earl Kency. Man, great show and informative. He also says patients get defensive a lot when you have the conversation about weight. But say you're doing the right thing, Dr. Kinsey. If they don't know, if they don't know you, they are more likely to reject it. So we definitely got to get folks connecting with PCP. You know what? And that's a great comment, Dr. Turner, because I'm gonna chime in on this because as a primary care physician, it's like so many people say, well, I'll say, well, who was your previous doctor? Who were you seeing? Oh, I didn't have a PCP. I just go to the ER. They know me at Baptist.
Yeah.
I'd be one of your patients. I can't see. And they say, man, I just go over there. I said, but guys, this is not the primary care office. The
Yeah.
ER is for emergencies, not to say I just came because I had a headache or I just came because I want to know if I'm pregnant. So we've just got to really help to stop the narrative around here that is saying And it's not just a problem in Mississippi. This is going on around the country, but of course, there's a lot of overuse and misuse of the ER. And like you said, Fred, you don't want to go talk about certain issues, but we talked about Medicaid expansion and the lack of it that some years ago when a different person was in office and a different person who looked like us was in office,
Yeah.
and a lot of things were rejected here. But this was already a state that was at the worst of the worst in terms of numbers and percentages, and then because of political reasons, things were rejected. So anyway, that's a whole nother talk. Let's see. She said Perkins, it's affordable, just not convenient. Parents and children want a quick fix. Yeah, absolutely. Okay, so let's check Instagram. All right, making sure. So let's go to our next question here. We kind of talked about that. Let's pivot. Let's go to Ozempic. That's a hot
Okay.
topic. Everybody wants to lose weight and get Ozempic. Everybody wants to get on it, but it's so expensive. So question is, can drugs like Ozempic be dangerous, especially for younger people or those who lose weight too quickly? Let's let Dr. Rayford start off on that.
Yeah, so I want to begin with any prescription medication has downsides. And so I kind of want to go, doesn't matter what problem you're treating, any prescription medication has downsides. And so you want to balance it against what you expect. Right now, this is a medicine that's used safely in a lot of different areas, of medicines that helping people improve their health. Right now, it's a medicine that still costs a lot of money and is something that's covered differently by different insurances. And so it's a good, helpful medicine. So the question is, with all the obesity that we have in the country and in Mississippi, should there be more Ozempic? And I would say that answer is no. The cost of Ozempic and its kind of weight loss cousin Wegovy is prohibitive, and I think a lot of Mississippians kind of there's an opportunity to improve. There's weight loss, but then there's health, right? So if I lose weight because I'm stressed, or I'm losing weight because I picked up recreational drugs, I've started my cocaine habit, and now I'm losing weight. That's not a good way to lose weight. And so
Absolutely.
it does matter the way, or if I'm losing weight because my diabetes is so uncontrolled, I'm maybe one sneeze away from DKA, but I'm losing weight. That's not a healthy way. And so all weight loss is not good weight loss. But the health habits, you talk about nutrition, you talk about exercise. So if we could make small interventions that got more people engaging in those health behaviors, what would be the society cost of doing that instead of 3 or 4 more Ozempic prescriptions in my patient panel? We might have better societal costs, but when society has got the pocketbook open, you kind of have to zoom out. No, I'm not going to be in my high school, prom tuxedo, but I might be better. I might have a more durable health benefit. But I kind of go back to, any prescription can be dangerous. And the more people use a medicine, the more likely you are to see even very, 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 very rare side effects. So when tens of millions or more people are going to be on Ozempic, you're going to see things rare, one in a million, 2 in a million kind of side effects. Those medicines are still safe, but you just crossed the threshold at which you're seeing, and that happens with anything, that once you go to the tens of millions to the hundreds of millions, you're going to see some things that you couldn't see in the studies that only had maybe a few thousand, 10,000 participants. So I will say that as time goes by and more people use Ozempic, we're going to learn a little bit more about those side effects. But right now, for many people, the upsides outweigh the downside. But then for some people, and again, that's worthy of having a conversation. I do not recommend you kind of, going online, engaging with just a transaction just to get Ozempic. I think you should talk to the people that provide your care and people that you trust from a clinician standpoint that has your health in mind, and kind of make that decision through that one. Obviously, the challenge with young kids I have to be honest, you got to be careful, because we've learned about some impacts that with weight loss. We do know that, sometimes the psychological impact of weight loss. You got people who had obesity their whole life and now they have weight loss, but psychologically that may still be hard because relationships change. Your food, kind of the way you connect over food changes. The attention you get changes. And so some people that may be very psychologically hard. So you may see some adverse mental health outcomes from weight loss. And with kids, we really worry about, we really want to make sure that, that you got a 12-year-old, maybe we need to work on body image. Maybe we need to work on kind of what that 12-year-old's value is, what their outcome is, because we might be contributing to a kind of a problem that's not going to get better with the weight loss. We may be, and so we have to be really, really careful with kids. And so, I know Dr. Kency, Dr. Kency's wife through MedPeds, when we talk about, pediatric obesity in adolescents for the interventions, we kind of have a really high threshold. We want those adolescents seen in specialty centers that have strong psychology services,
Mm-hmm.
as well as nutrition services, as well as clinician services. And so we want that to be a very, very structured and appropriately so. You got a developing brain, you got body image issues and all the other stuff that can kind of happen in adolescence. And so you really want to be, so I'm definitely, I have no problem with, assisting patients who are adults and they're at the point where they're considering medicines like Ozempic, but then adolescents, because usually it's somebody else that may be driving that adolescent. It's a grandma, it's a mom, it's somebody else that's kind of driving it. And you just want to make sure that before you do anything that has risk, you want to make sure y'all are all on the same page about what to expect.
Yeah, absolutely. Absolutely. We've got a couple of question and comments here. Shalitha says direct pharmacy distribution is more affordable, but it's still not economical for the average patient. In addition, I was informed that Ozempic has a patient assistance program for those below the federal poverty line, or those or that patients that have Medicare or no insurance at all. Well, Shalitha, look, I would love for you to put some of the information on here because look, I don't know about you guys, but people come in left and right all day. You've got at least one or two patients asking about it. And then, for the most part, since it came out, it's been about $500 a pop.
Mm-hmm.
And so I actually didn't know that there were any assistance programs. So that is definitely earth-shattering news. So I appreciate your input on that. And if you could get us that information or get it to me, I'll be happy to share that. So. And then we've got my good friend Jasmine Briscoe. I know before I even read this comment, fellas, she's an amazing licensed massage therapist, and I joke with her every episode. I think you might have missed us on the last one or two, Jasmine, but she's absolutely amazing, and she's gonna always link something to lymphatic drain. It doesn't matter what we talk about. I done had comedians on here, all kind of folks. She's gonna mention lymphatic drainage. It don't matter, pastors, all kind of folks. So Jasmine's encouragement of more natural detoxification and nutrition options should be enforced more. Manual lymphatic therapy and infused water. So yeah, absolutely. But yeah, the diet, man, just like you guys were saying, and Fred, you were talking about these food deserts, and unfortunately, it's just not available. And Jasmine's talking about these healthy options and detoxification, but people just can't. I mean, they just can't afford it, especially if it's a single parent and working two jobs. And we all know that the wages are down and the cost is up. And so it's just so many. The question that I asked earlier about why so many people are disenfranchised here in Mississippi. And it's just because of all those things, again, that are affecting people all over the country. But It's particularly pronounced here. Fred, any thoughts, Fred, before we get to our next question?
Oh no, I think Dr. Rayford did an amazing job at
Yeah.
discussing the Ozempic and the tirzepatide, zip bound type of things.
Hmm.
I definitely believe that uh, for younger people, um, if an adult makes an adult decision about wanting to do these medications to try to lose weight, to be more healthy, to have less weight, to walk more miles, to do these kind of things, I'm all for it. For
Hmm.
younger people, I think I'm less inclined because I want to see them build the discipline necessary to lose it on their own.
Hmm.
You know, there's a huge thing about having that discipline to get up in the morning and go walk a mile before school,
Hmm.
having that discipline to walk a mile after school. Um, some of these things will definitely take a lot of help from the parents too. So if the parents don't want to walk, the kids aren't going to want to walk. If they don't have a motivation to do it, they aren't. But I definitely agree with everything that Dr. Rayford said, and we got to do whatever we can to get the obesity problem under control because it's definitely ending lives much younger than they should be.
Yeah.
Absolutely. On one of the shows, well, on a few of our shows, we tried to make sure to take away this myth that there's such a thing as big boned. And I tried to tell people, since we're talking about obesity, I said, now listen, this is a thing. Now, this is specific to the South, Mississippi and Alabama, and, Georgia, things like that, Louisiana.
Oh yeah.
Yeah, where people say, well, all my people are big bone. I would love for you guys to weigh in because, see, people, they get on me. They say I'm too straightforward, or I've even been labeled as mean if I talk about big, that there's no such thing as big bone. And you just, you got to push away from the table, and we're just too greedy. It got nothing to do with your bones. Your bones are the same, everybody. So I just want the audience to hear from two other physicians so they don't think I'm crazy. I'm not just being mean and saying people are just, well, we won't say the F word because everybody's getting canceled today,
Mhm.
including, brother Kimmel. So we won't say the F word, but hey, it just is what it is, folks. There's no such thing as big bone. But I want to let, again, other two board certified, licensed physicians weigh in on the concept of big bone, because especially with people giving that excuse, and since we're talking about pediatrics and children, we're utilizing that as an excuse and even labeling and making it okay for the children. Because when all of us guys, when we grew up, I don't know about y'all, it might have been one or two kids, that were, maybe overweight or obese. That was not common. But today it is just like everywhere. And people make excuses for that using the
Yeah.
term big bone. So anyway, your thoughts, gentlemen.
Yeah, I'll
You
just
know,
add.
oh,
Yeah, I'll go and just add that, it takes a lot of conversations, and primary care, you definitely got to have that relationship, that long longitudinal relationship. And, I might approach it over a spectrum. We might kind of just say, hey, I might bring it back. There may be some other items on the agenda. Maybe that first visit, it doesn't get brought up. Next visit, it may come up. I'm definitely asking permission. It's just always cool, always good to just kind of ask permission. Hey, can we talk
Mhm.
about it? Hey, I'd like to talk about your weight. You fired a warning shot. Now, some people have been stigmatized so much about their weight that that visit might not. I mean, when that person just kind of shuts down, they're in a fetal position and all that, you're not going to accomplish anything. And so, out of kindness, I let it go. But then we just talk about, let's just talk about, assessment. I tell people that the BMI gets the conversation started, but then there's some other things I'm going to do to just kind of make sure that I'm answering this question. Your weight is this, and how much risk does that weight bring to your health? And so I'm talking about waist size. I'm thinking about fat percentage. I'm thinking about all those other things that we know convey risk. I'm thinking about presence of chronic comorbidities. And so at the end of it, I hope my people understand that I'm not treating everybody the same based on
The same.
BMI. I
Hmm.
started the conversation at a BMI, but then that conversation ends with a personalized Vernon Rayford assessment of elevated BMI plus this, and this. And then we just talk about, we talk about ways to get started. But I mean, it's a long conversation. I will say, having tried to practice obesity medicine in the middle of primary care, it's hard to practice obesity medicine well. You need time with the clinician and the patient. And many times early on, you may be trying to undo decades of like weight related bias and stigma.
Right.
It's just, people who visibly are heavier than others, they are exposed to stigma and bias from all corners. And so we might be dealing with that early on, and from a place of psychological, like, trying to get a place of psychological safety before we can kind of get, before we can kind of get toward these are the specific hard things that's going to help you be better. Um, but I will say, that concept of big bones, and like I tell patients, is you don't want to try to explain away all of these things. People explain away their blood pressure. They explain away. We need to just let the numbers speak for themselves and have that question of, well, what is my risk? And let that kind of flow. But I know I got to be out here talking about it in the community, because sometimes in the exam room, I'm more and more pressed for time. And so I appreciate you, Brother Michael, for putting on stuff like this, because we physicians are not going to, and clinicians are not going to improve obesity in the exam room. We're not going to do it in the ER. We're not going to do it in the operating rooms. We're going to have to do it out there in the community where people spend their time. So we're going to have to be at the churches and the health fairs. And so I appreciate being on with brothers who are clinically sound, top of their practice, but also community engaged.
Yeah, I appreciate that, brother. We've got some things that flooded on in, so I'm going to try to get us some quick responses, gentlemen, because I know we're getting close to the time. So we've got several of them coming in, so we're going to do our rapid fire, as they say. We'll give
Okay.
them some quick answers. All right, I'm going to start with Dr. Justin Turner. Then I'm going to go to Instagram. We've got Doctors Pierre, uh, and they have a question on Instagram side, and then we'll come back to Nurse Octavia, and then this is an interesting comment there by nurse practitioner Martin. Another myth is BMI is for whites only, and that's a
Mhm.
whole nother topic. All right,
Yeah.
Dr. Turner, should pregnant moms be concerned about Tylenol usage in early pregnancy as it relates to autism, given the new news from the White House? Not sure if this was discussed. Okay, yeah, and Dr. Kency did touch on it. Mississippi has amongst the highest maternal mortality already. How does this impact pain management in pregnancy in a state where Black women are dying 4 times worse than others? So I'm going to leave, that was a big one there. I'm going to leave that up. I don't know if Dr. Kency, since you did talk about that a little bit before, if you want to address that quickly there.
Look, I've told folks that have asked me on social media and other entities since this news was released on yesterday, is that ACOG has placed a statement out there, and it's very succinct. And let me pull up on my phone so I don't blur their words, because they made it very easy to say.
Yeah.
ACOG, the American College of Gynecology, says that obstetrician and gynecology, it says that in more than 2 decades of research on the use of acetaminophen, and notice how I said that correctly, somebody didn't yesterday. Acetaminophen.
Sing.
And
Hold on, Doc. Say that. Hold on, I got it. Say that again. What'd you say yesterday? Somebody say that again.
somebody might have chopped that word up into a couple pieces in order to get it out, but in more than 2 decades of research on the use of acetaminophen in pregnancy, not a single reputable study has successfully concluded that the use of acetaminophen in any trimester of pregnancy causes neurodevelopmental disorders in children. And that is from the president of ACOG. the governing bodies of
Boom.
all OBGYNs.
Boom.
So, that is the statement that I give my patients. When we look at studies, not every study is to be taken to heart. There are things called quality of studies. Um, and when you look at a quality study, as the one that ACOG discusses in their papers done in Sweden, the highest quality study that we have out there, causation does not exist. There is no association that Tylenol directly causes autism. Um, there's a lot of confounders, a lot of biases, um, but we have to stay the line. We have to depend on evidence-based medicine. We have to depend on our education and understand that you have to critically break down what studies are, because there's very often someone will say, "Well, look at this study I have." Well, your study had 42 people in it. That's not really something that we make
No,
life changing
no,
decisions on in any part of medicine with
not at
42
all.
people.
That's not a lot of
Well,
power.
this
Yeah.
this this study reviewed 21 other studies. Well, they initially included 400 other studies, and only 20 of them could be included because they met the criteria. So when you look at some of those things, you have to be very critical in what you do when it comes to a study. And when non-physicians, non-scientists tell me about the studies that they read or that they heard about or they want me to look at, one of the first things you look at is, does this study have any bias? Who performed this study? Was it done by a pharmaceutical company? Was it done by a college of institution? Was it done by this? Was it done by that? And the next thing you're looking at is the power of the study. Like how many people did they actually interview? How many people were actually included? Because if the study lacks any power, then it's worthless to look at, because that means that the likelihood of you replicating this study 15 times in a row and getting the exact same answer is highly unlikely. And so you have to be very careful about when you look at a study and say this study said or this study concluded, because it's not always meant to give the information that you think it's meant to give, and it's not always going to be reproducible multiple times down the road. So
Absolutely. I want to go. I want to make sure we can get. Wait a minute. Get these in because we've got a few others
but the
here.
gist of that is listen to your physicians, don't listen to people on TV.
Absolutely right.
Yeah.
And look,
Yeah.
and Dr. Kency,
Yeah.
I want to do you one and piggyback on that one. Doctor, the president, which you were referring, Dr. Stephen J. Fleischman,
Mhm.
MD, MBA president, like you said, of the American College of Obstetrician and Gynecologists. He says that suggestions that acetaminophen use in pregnancy, the suggestion that acetaminophen use in pregnancy causes autism. Those suggestions are not only highly concerning to clinicians, but also irresponsible. So I just wanted to put that out there quickly. Um, let's see. Let's go to Instagram, Dr. David Nardarian Pierre. They're saying, speaking of body image, and after that, we'll go to, after I think we had another from Octavia Simmons. And then I see Brother Terrence Ware on there. We're going to get to you, my brother. So they say, speaking of body image, what's your approach to parents on the topic of social media, cell phone usage? This, in addition to gaming, plays a large role in childhood obesity and health. All right, let's start with, let's go to Dr. Rayford, and let's
Yeah.
try to keep like, it might
I
be hard,
got you.
45 seconds with rapid fire. Let's go.
Hey, rapid fire. Hey, so certainly there's a negative impact on kind of, the gaming and social media and phones kind of impacting in terms of exercise. But more concerning and scary is the negative impact on mental health and well-being. So, if we just imagine if we had access to the worst in adults, if as we were growing up, our kids, they may be mature sounding, but they're still immature. And so, I would just say that with social media in particular, the later you introduce it and the more you introduce it with yourself with strong safeguards, the better. The earlier you introduce it, the more risky. And you really need to contend. You really need to see what they have access to, because it's a few keyboard clicks, and these kids are in the worst. They in the worst holes on internet, Snapchat, Reddit. You got to be careful. Discord, and I mean, you got to just be really really careful. So I would say, in larger, like, enabled devices, I think the recommendation is that, kids don't even start getting like smartphones with full features until high school. And I support
Mhm.
that. I know people, kind of have to make decisions they can but nowadays with these algorithms, man, you start looking at something and it starts spitting it back out at you. I mean,
Mhm.
I'm more concerned about social media now over the last 2 weeks than I ever was. And I think it's clear pediatricians and clinicians who take care of adolescents, social media has just gotten more risky. Like,
It really
it's
has.
hard for me to even suggest the upside on social media. It's just, as time goes by, it's just seemed more risky. So I'll tell parents, man, it's risky. Your kid's gonna be unhappy, but it's just risky.
Yep, absolutely. Um,
Yeah,
let's
I'm
see.
right there with
Go ahead. Yeah.
Dr. Rayford. I'm right there with Dr. Rayford. Prevent exposure to social media, and the fight is not as hard. Don't let your kids even know that there's a Facebook or an Instagram. Don't, whenever they go and stay with other people, other family members, let them educate them. Do not expose my children to social media. My kids don't, my oldest is 10, his youngest brother is 8. They have friends that have cell phones, they have friends that have Facebook accounts, and they already know. Don't even ask dad those kind of questions. It ain't happening,
Yeah.
because there's like Dr. Rayford said, there is 10 times more negatives than giving a kid social media than there are positives.
Hmm.
And that's just
Absolutely.
the mental health side of it. That's not talking about the physical health. That's just the mental health. The things they see, the things they read. A 10-year-old, a 12-year-old, 8-year-old, they are sponges. They soak up everything they read, everything they hear. And so when they hear the negative, they don't know how to block it out, to ignore it. They're going to come to daddy and say, Daddy, I just saw on this blah 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 that this is this. And now there's a conversation that's happening that didn't really need to happen, because you didn't need to give them access to social media, because there was nothing positive they were going to get from social media anyway.
Hmm.
Nothing. There's
That's right.
nothing positive for a 10-year-old on Facebook or Instagram or whatever these other younger, Discord or wherever these younger social media avenues are. And so
Hmm.
I tell parents all the time, prevent the access to those social media types as long as possible. Prevent the access to phones as long as possible. My kids have iPads. They're able to FaceTime family members, their little cousins, me, their mom. They play Roblox, and so they can play on those video games. I've disabled the chatting mechanism, so they can't actually, like, people can't talk to them. They can't talk to other people, but they can play the game, and that's how it should be. They're focused on. I mean, I want them to be able to learn how to use technology. I don't want them to be technology illiterate, but I don't need them manipulated by social media, because like Brother Rayford said, there's just not a lot of positives to social media for a child that age. That
Right.
sponge, let me feel the sponge. I don't want social media filling my sponge.
Yep. Absolutely. Let's go to Octavia. Not, she said, not sure if I'm off topic of what you all are discussing tonight, but can we discuss women in our early to mid 40s experiencing weight gain, brain fog, and hair loss? I've noticed some of these things within myself, and friends have also voiced that they're experiencing the same things. What are your thoughts on what we are experiencing and what you recommend to help? I'm gonna tackle this one real quick, and then you
Yeah.
guys, the first thing that jumps out at me, maybe probably for y'all too, is thyroid disorder. Hypothyroid. A lot of people are walking around with untreated thyroid disorders, and and that may not be the case, but this is like hallmark, what we say, in med school, hallmark things, with issues with hair loss, weight gain, brain fog, fatigue, all of those things. You may or may not have something that you can feel, or like what they call a goiter or something palpable or mass or in your neck. But it just may be that you do a simple blood test, a TSH level, all that free T4, and you look at blood work, say, man, these levels are off. And some people, if that is the case, they get treated, get the hormone replaced with levothyroxine, Synthroid, and next thing you know, man, and a month later, they're back to normal. That may be it, but there's also other things. There's depression, other things. So anyway, that was just, I wanted to chime in very quickly. Let's go to Dr. Kency first.
Yeah, I agree with that. That's always a conversation I tell my patients to have with their BGYN or their primary care doctor. As an emergency doctor, we're not, someone comes in with, I'm fatigued. That's
Yeah.
not really my scope of practice. And I try to be very transparent with patients when it comes to the appropriate usage of emergency rooms for their primary care problems, because this is a real issue. If you're having weight gain, it affects you physically and mentally. If you're having brain fog, it can affect your ability to do your job. It could affect your ability to have sustainable employment. So these are really important things. If you're having weight loss, what does that do to your body self-image? What does that do to all these things? And so I'm real big on, this is an important topic. This is an important health issue. But the emergency room is not the place that will fix this problem.
Absolutely.
You need to see your primary care doctor. You need to see your OBGYN doctor. You need to be discussing things like thyroid issues, healthy weight, because if you're very obese, that can affect your ability. That can affect issues with hair loss and weight gain. If you're going into perimenopause, that can affect all of these things. Mood disorders, it can have a huge effect. Different medications that you're taking that you didn't even know could cause some of these issues. Medications that some things that are considered natural medications, multivitamins that you started, can affect a lot of these things as well. So I tell patients, you need to have an open, clear discussion with your primary care doctor, your OBGYN. Make sure that you write these things down before you get to the clinic. One of the biggest issues that patients have is they get to the clinic and they can't think of all the things that they want to come and talk about because they don't have them clearly articulated and because they don't have that list ready to discuss.
That's
If
right.
you've already written it down, if you've written it down on a piece of paper, hey, I want to talk about this, this, and this. These are my 3 important topics to talk about today. That physician may be able to truly address and tackle those 3 things very expeditiously. But if you come in with one problem and then you're 22 minutes into your visit, they're like, oh, yeah, I also want to talk
Oh, yeah.
about this.
That's right.
Well, I mean, we probably could have if I had known that you wanted all these 3 things discussed at the beginning of the visit. And so now I can't help you with all 3 of these things. I can only address one of them. I'm gonna do my best to make sure we do the best work we can to help you out. But those are the kind of things that need to be addressed with your primary care doctor. And I'm sure, and we can't always find an answer. A lot of times patients get really, annoyed with physicians when we don't find the answer. You know, from an emergency room standpoint, I tell people, my job is not always to get the answer, but it is to rule out things that are life-threatening, limb-threatening, sight-threatening, and also to point you in the direction of a person who I believe can help you the most. If that means going to a cardiologist, that means going to an endocrinologist, that means just going to your primary care doctor because you started halfway down the race when you should have been back at the starting line because you jumped the line. A lot of times that's the most important thing is that if you just go to the right person, this can be a very easy fix. But I'm not the right person.
Yeah.
I'm the right person if you sprain your ankle and if it's turned backwards. I'm the right person if you cut your arm and it's bleeding. I'm the right person if you have some chest pain and you don't know where it's coming from. I'm the right person for that. If you're tired, or if you feel like I'm losing some hair, I'm not the right person for that problem, most likely. Tired can actually come from, I've had quite a few patients where their fatigue was because their blood counts were drastically low. So that is, so I don't write off the word fatigue when I see it on the patient's complaint chart because that can be a medical emergency. So I try to be a good steward of every person's complaint is important. And I do my best to make sure that I rule out those life-threatening, limb-threatening issues. But most of the time, your primary care doctor for some of these problems is the best place to go.
Yeah.
Absolutely. Absolutely. Jamie, good to see you, Jamie. Thank you so much for joining. She says, we need to maintain a healthy diet and a consistent workout routine. I really enjoy following the New Start program. Um, Going back to Instagram quickly, I know we're over time. Doctors Pierre was saying the stages of perimenopause are a huge factor as well for women approaching and beyond their 40s. And Dr. Kenson, we love that you highlighted the importance of taking notes to bring to their visits. Uh, I think we've gotten caught up. We've gotten everybody. I know we went a little bit over. Man, this is fantastic. I want to give the floor to you guys to make any final comments, and also thank you all for being here, and also to let you guys have the floor to let the audience know, where you can be found, what you're doing, what events you have coming up, and whether you're taking new patients. Well, I mean, Fred, you're in the ER. Well, that's right. You can tell them about the marijuana practice. I don't want to steal the thunder, so I'm gonna let him tell you about his practice, some other things he's involved in. Started a new business over there by Capitol Grill. So I want to go ahead and give the floor to Dr. Rayford, and we'll let Dr. Kency close it out. Just let them know who you are, where you can be found, what events you're doing, and if you're taking new patients.
Yeah, so I just want to thank you for kind of lending your platform, giving me a little
Yes,
bit
sir.
time to talk. It was, hey guys, I just want to acknowledge that it's good to be on with two other brothers in
Yes,
medicine, and
sir.
just kind of acknowledge that the meaningfulness to me, just as a black male physician, to kind of be share stage with leading black male physicians in the state. Also having Dr. Justin Turner. So you guys, you got four black male physicians in Mississippi. I wouldn't call us unicorns, but we're pretty darn close.
Very
Uh,
close.
so I mean, and I just want to thank y'all. Thank you for this kind of opportunity and the fellowship, man, and
Yeah,
man,
brother.
and look forward to kind of you tell me where you need me to be. I'm in Tupelo. Work with a internal medicine residency practice, so we are accepting people. We have 60 residents.
Wow.
So our doors are jam packed wide open. We serve Northeast Mississippi, Northwest Alabama. I know it's a bit of a drive for folks around Jackson, but look, if you're listening out, you got people in Northeast Mississippi, the internal medicine residency program. Come on, we because we're a training program, we have some flexibilities that other clinics don't. And then in the community, I serve as medical director, so that Good Samaritan Health Service is actually a free clinic. And so we certainly want to just kind of make sure we're meeting the needs of the community. So if you can't come through my doors at the residency clinic, we'll see if we can get you through the doors at the free clinic. And just kind of want to just add as far as events and Dr. Bookhardt, if you don't mind sharing with your audience some of the upcoming Mississippi Medical and Surgical
Oh yeah,
Association.
absolutely.
Um, we're going to actually have a webinar on next Monday, the 29th, about cholesterol. September is Cholesterol Education Month. Dr. Richard Rayford, who's a cardiologist, is going to be helping lead that talk. So just want to encourage everybody who can to join us for that event. And again, I'm appreciative and I thank you.
Yeah, absolutely. Thank you, brother.
Oh yeah, so Fred Kency, like Brother Burkhardt said, I'm a practicing emergency medicine physician here in Jackson, Mississippi. I practiced at the Baptist, previously practiced at UMMC, and I've worked in emergency rooms across the state, and I've had an amazing time, treated a lot of patients, and I hope I've done a good job and a good steward to take care of everyone equally. I have a company called Kency Medical Services that does certifications in the Mississippi Medical Cannabis Program. So we certify patients to visit dispensaries for medical cannabis. When we say medical cannabis, that means for medical conditions to include things like intractable nausea, vomiting from cancer, chronic pain, HIV, and the nausea, vomiting that comes from some of those medications. Things like cachexia, so appetite stimulation. We currently service right at about 3,000 patients a year in our clinic, and every year we're growing at about 15 to 20%. So we've had an amazing opportunity to take care of patients. We don't believe that cannabis is the do all end all to chronic pain and some of these other diagnoses like PTSD, but we do think it is one of the things that we have in our arsenal to treat some of these chronic conditions. And I can tell you from the patients that I take care of and the comments they give me and the discussions that we have, we are definitely making a difference, and patients are appreciating it. And not just the patients, but the patients' families. I can't tell you how many times I've had a husband or a mother or a father or even a child come and tell me how they're so happy that mom, dad, husband, wife, granddaughter doesn't take tramadol every day anymore, doesn't take Percocet every day anymore, doesn't take Norco every day. Not to say that every patient is going to come off of all of their Norco and Percocet and tramadol and gabapentin and Lyrica and all these things, but if we can just decrease a little bit of what they're taking, just a little bit, for the purpose of doing a gummy at nighttime to help them sleep, to help them with their chronic pain in their legs, help them with their restless leg, their neuropathy in their feet and their hands. We can do a huge amount of good to remove the opioids out of the home, because when we take them out of the house, then we decrease the risk of someone else getting access to them, whether it be children, grandchildren, with anyone who just should not have access to these things, because we know that we have a huge opioid epidemic going on. And so the more we can do to decrease the number of those prescriptions that are written, the more we can do to help our communities be safer and healthier. Also, recently opened up a cigar shop. When you talk about community health and then you talk about cigar shop, don't always go hand in hand with each other. But
You can.
the cigar shop, for a lot of people, though it may not be the healthiest place to hang out, from a mental health aspect, is actually an amazing thing for a lot of folks. So, we have a lot of
Mhm.
guys that come into our cigar shop that don't even smoke. They just come in, they just kind of hang out. It's their place they go before they go home to
That's
decompress
right.
from their day.
That's
They
true.
come in and have they'll come in and just have a Coca-Cola, sit at the bar and just watch the TVs, because they know that it's a place where they can mentally decompress. They're not at work, they're not at home, they're just there. And we appreciate them for supporting our business. But it's called Churchill Cigar Shop. It's right next to Capitol Grill, I-55 North, 5050 I-55 North. It's the old Radio Shack. So we've been open now for about a month. We've had an amazing success with what's been going on so far, and I look forward to keeping it going.
Yep, absolutely, man. Thank you all so much for that. We've got um, some significant comments. I'm gonna read these real quick, and we'll close it out. My great friend Jamie, tuning in from Maryland, um, said, "Thank you so much, doctors, for dedicating your time to educating people about the many illnesses impacting millions. Your hard work, skill, and knowledge are truly appreciated, and wishing you all continued blessings." So great seeing you too, Mike. Yeah, so thank you so much for joining. And lastly, Dr. Turner want us to mention that Dr. Rayford is president of the Mississippi Medical and Surgical Association, doing some great things, leading the statewide organization for Black physicians, educating our communities, training the next generation, and and empowering everyday citizens to be their best selves. Yeah, man. Look, Dr. Rayford said earlier, man. Dr. Turner, man, thank you so much. You been somewhat of a I don't know, you probably only maybe 1 year older than me, but but you've been practicing a couple years longer, and so appreciate you as being a big brother, someone I look up to, man, and for some guidance and all the tremendous things you're doing, man, with working with Jackson State and with your clinic, and now with UMC, and you was state with the state office, Mississippi Department of Health, as you being over that as chief medical officer previously. So thank you for everything you do here at the state as well. All right. Well, again, man, gentlemen, I appreciate it. But Fred, I'm gonna see you. I'm gonna see you soon. Um, and so thank you so much, guys, for lending your time and talents, and for all of you who stayed with us over time, 23 minutes over. So look, I'm gonna get out of your hair. So just briefly, and I usually try to leave it as a mystery, but I can't go without letting you guys know our next guest next Tuesday, 7 p.m. Pilot, captain, you would say, Captain Joy Schweitzer. I think that's how you pronounce her name. African American female commercial pilot. I don't want to say the company she flies for. I don't want to get that wrong. But I met her on Instagram. She's phenomenal, doing some big things, and the first African American female pilot that I've ever seen. And so she is going to be with us in the building next Tuesday at 7 p.m. You don't want to miss it. So you never know who you'll see here at Telehealth Tuesday. So again, thank you for watching. We love our fantastic audience participation. This has been a great one. And so we hope you'll join us next week. Bring a friend. Don't be selfish. Don't keep it to yourself. Bring somebody else. If you want to see either one of these gentlemen, both of these gentlemen, again, let us know. If you want to be on the program or you have somebody else that you want to suggest to us, we would love to hear that feedback. So we'll see you next Tuesday, God willing, 7 p.m. And always remember, oh, by the way, and you guys stay, if y'all stay after with me for like 5 minutes, my two guests. So always remember that true wealth begins with good health. See you next Tuesday. Let's see here. Yeah.